Hello, my name is Peter Lawrence, and I'm pleased to introduce the December issue of the Journal of Vascular Surgery, and to highlight 4 outstanding papers which are freely available for the next 2 months. Our editor's choice article is Cost Effectiveness of Transcarotid Artery Revascularization, or TCAR, versus carotid endarterectomy by Christina Cui and co-authors. They conducted a cost-effective analysis comparing TCAR to carotid endarterectomy for symptomatic patients with carotid artery stenosis. They used a Markov simulation with quality-adjusted life years, cost, and incremental cost-effectiveness ratio over a 5-year period. For symptomatic patients, the CEE, or carotid endarterectomy, cost $7,821 for 2.85 qualities, while the TCAR costs $19,154 for 2.9 qualities, leading to an initial ICER, or cost ratio, of $152.29 per quality in the TCAR arm. The study found that while 5-year costs for TCAR were greater than carotid endarterectomy, TCAR afforded greater qualities than carotid endarterectomy, and TCAR became cost-effective at 6 years of follow-up. The next article is Predictors of Clinical Outcome of Fenestrated and Branched Endovascular Repair of Complex Abdominal and Thoracoabdominal Aortic Aneurysms in an Italian multi-center registry by Galito et al. The authors reported an Italian experience from 4 academic centers that evaluated predictors of outcome with repair of complex aortic aneurysms, including juxtarenal, pararenal, and thoracoabdominal aortic aneurysms. 596 patients underwent fenestrated or branched EVAR for 124 juxtarenal aneurysms, 121 pararenal aneurysms, and 351 thoracoabdominal aneurysm. Elective procedures were performed in 87% and were urgent in 13%. Postoperative cardiac, pulmonary, and renal complications were reported in 7, 8, and 13% respectively, while 1% had bowel ischemia and 4% had cerebrovascular complications. 8% suffered spinal cord injury, and 3 had permanent paraplegia. Crawford's category extent 1, 2, and 3 thoracoabdominal aortic aneurysms and postoperative renal complications independently predicted spinal cord ischemia, with odds ratios of 13.4 and 3.8 respectively. 5% of patients died in the perioperative period. Preoperative chronic renal failure, postoperative bowel ischemia, cardiac and cerebrovascular complications, as well as spinal cord ischemia, were independently correlated with 30-day or hospital mortality. Survival in this group of patients was 88% at 1 year and 78% at 3 years. The authors concluded that fenestrated or branched EVAR is associated with satisfactory midterm outcomes, but a variety of risk factors should be considered in fenestrated EVAR procedures, both pre- and post-operatively, to reduce complications and improve survival. The CME article this month is by Rahman and co-authors. Claudicating patients with peripheral artery disease have meaningful improvement in walking speed after supervised exercise therapy. This study examined the minimal clinically important difference in walking speed in claudicating patients after PAD that had been treated with supervised exercise. The ability to walk 1 block and the ability to climb 1 flight of stairs questions were chosen as what are called anchor questions. 63 patients with PAD-related claudication had self-directed walking speed and stair climbing measured before and after they underwent supervised exercise therapy. Claudicating patients who increased their walking speed by 0.04 meters per second or greater and those who climb stairs in 0.03 meters per second or greater are more likely to experience a meaningful improvement in walking impairment than those who are not. This study can serve as a benchmark for clinicians to develop goals and interpret progress in the care of claudicating patients. The final article, by Kim and co-authors, is Outcomes of Bypass and Endovascular Interventions for Advanced Femoral Popliteal Disease in Patients with Premature Peripheral Artery Disease. This study compared outcomes in premature or young patients with PAD who had undergone femoral popliteal bypass or endovascular revascularization using the Vascular Quality Initiative, or VQI, vascular intervention files. Of 2,538 patients, 902 underwent isolated FemPop endovascular intervention, and 1,636 underwent femoral popliteal bypass. After propensity score matching, 466 patients in each group had no significant differences in the baseline characteristics. Perioperative morbidity was higher with femoral popliteal bypass compared with endovascular intervention, with 12.0% for femoral popliteal bypass and 8% for endovascular intervention. However, the rates of major amputation and mortality were not different. At 1 year, patients who had undergone a FemPop bypass were less likely to undergo or require re-intervention, 17% with FemPop bypass versus 25% with an endovascular procedure. However, no differences were found in major amputation or mortality. In addition, FemPop bypass with saphenous vein and isolated FemPop endovascular interventions were similar. The authors concluded that in patients with premature PAD and advanced femoral popliteal disease, bypass surgery decreased the reintervention rate at 1 year, but was associated with an increased perioperative morbidity, and the hospital length of stay was longer compared with endovascular surgery. And no differences were found in major amputation or mortality between the two strategies. Thank you for watching. For more information, please follow us on social media and remember to like, comment, and share. We hope you enjoy these 4 highlighted papers and the other excellent papers in this month's Journal of Vascular Surgery. Remember that these articles are free to read until the end of February. And thanks very much for your attention.